Okay, so a proper introduction to cardiac output, which I haven't done yet. Cardiac output, how much the heart pumps per unit time, okay? Stroke volume times heart rate. 5.6 liters in young, healthy men, 4.9 liters in young, healthy women. Mostly because the difference here is because of body size, right? If you have less body, you need less cardiac output. So that's the difference there. Amount of blood which enters the aorta per minute, also the amount of blood which flows through the circulation, right? There's only one heart, so whatever comes out, that's the only source there is. Venous return, quantity of blood entering the right atrium. In general, venous return has to equal cardiac output or you're in heart failure, right? In other words, the blood that comes back has to get pushed forward. Now, in the second to second, it never exactly matches, all right? But we don't call it heart failure unless the backup is continuing hours to days at least. So a few beats at a time, things do absolutely change. We call that beat-to-beat variability, and that's fine. The Frank-Starling mechanism is VR increases, end diastolic volume decreases, and systolic volume decreases, end diastolic volume increases, right? So the more blood that comes back to the heart, the more blood the heart pumps out. Remember, this is related to the stretch, that when we're a little stretched out, sarcomeres work better, so it contracts more effectively. Things that increase cardiac output, right? Sympathetic nervous system can increase heart rate. That directly increases cardiac output. Contractility, that increases a smaller ESV for a given EDV. That's contractility. Okay, so that's going to increase stroke volume and therefore increasing cardiac output. Venoconstriction, venous return related, right? Oh, and total peripheral resistance. The sympathetic nervous system tends to increase TPR. That's vasoconstriction, right? Remember, the sympathetic nervous system innervates all the vessels. So when it's active, a lot of constriction, a lot of resistance, increased total peripheral resistance. Now, you can't just keep increasing TPR to get more blood pressure. At some point, you've increased your resistance so much that now the heart can't push hard enough to move blood around. Okay, that's this parentheses bit. Too much TPR will start to reduce cardiac output because of afterload. All right, the higher your TPR, the higher your ESV, and therefore the lower your stroke volume. See, it starts to fall off. And believe it or not, we actually encounter this in our care of patients in the ICU. Like, you can always get the blood pressure you choose, okay, with enough medicine. The problem is, at some point, you have so much vasoconstriction that your blood pressure is 120 over 80, but your fingers and toes are stone cold, right, because they're not getting any perfusion. So cardiac output starts to fall off if TPR is too high. Parasympathetic inhibition increases heart rate, stimulation decreases heart rate. Hypertrophy. Okay, so if the heart has to work hard for long periods of time, like over weeks to months, it hypertrophies. It gets heavier and stiffer and stronger, right? So long-term increases the mass and strength, right? So what does that matter? Why does training our cardiovascular system help? It increases stroke volume by decreasing ESV for a given EDV, right? In other words, for a given fullness, a fit heart contracts more completely than a not fit heart does. Okay, it's why very fit folks can have a heart rate of 45 or 50, right? And it's because their stroke volume is so high that they don't need much heart rate to create resting cardiac output. So more stroke volume with each beat means a higher cardiac output for a given heart rate. So that can have a big effect. Plasma volume. Plasma volume directly relates to venous return. More venous return, more stroke volume, right? So these are all the same factors that were on my very messy diagram. Now, opposite, decrease, also true. Increasing arterial pressure, that's afterload, right? So as our resistance goes up and our diastolic pressure goes up, our afterload goes up, which increases ESV and therefore decreases stroke volume. Okay. Inhibition or blockade of the nervous system, so like no sympathetic tone, that's our spinal anesthesia that we talked about yesterday, okay? Or anesthesia of any kind that knocks out the central nervous system. Abnormal contractions or rhythms. Remember, we are dependent upon atria contracting first, ventricles contracting next in order to push blood forward. If we have abnormal contractions or abnormal rhythms that messes that up, well, obviously we're going to lose our cardiac output. You know, like ventricular fibrillation, the heart never really contracts. It just sits there and quivers, right? So we never get a stroke volume. Valve disease will decrease cardiac output in a variety of ways. It can be restrictive, like a stenosis, in which case it behaves just like a high afterload, okay? It can also be a regurgitation where the valve doesn't keep blood from flowing backwards. So in that case, your heart is working hard to push blood the wrong way, right? So you have you're defeating yourself. And then in myocarditis, that's where the heart muscle itself is sick, either from infection or inflammation or metabolic derangement. And that, the effect you're going to see again is in ESV. If the heart is sick, it won't contract as well, right? So the ESV is going to be bigger and the stroke volume will be smaller.